I have cancer. No. If this is normal for you and you've always had it, then no. But if you've never had it, if you've never had ribbon-like stools, okay, and now you do, ribbon, you know what a ribbon looks like, right? Thin, yes? So if you've never had ribbon-like stools and you have it now, then yeah, now it's a problem. But if you've always had it and that's baseline for you, that's not a problem, okay? Abdominal pain, diarrhea, vomiting, rectal pressure, okay? Obstipation, which means this is more than constipated, you're now obtunded as well, okay? More and more women are getting colorectal cancer today. I mean, when we fought for equality, we didn't mean this. We meant more money. All right. Diagnostic tests, well, we talked about that. DRE, guaiac, sigmoids, colonoscopy, and barium enema. And your treatment is slash, burn, and poison. There are some oncological emergencies that can occur. Remember, what we do with chemotherapy and radiation is that we kill everything, right? All fast-growing cells. Well, if we kill, and in the past, a lot of people used to die from sepsis because we would give chemotherapy treatments 3 days in a row, 5 days in a row, 7 days in a row, or 2 weeks worth of chemotherapy and then stop, okay? And a lot of people would die from complications of sepsis because, remember, our white cell count, we just killed them all out. Okay, so our immune function is down, the white blood cells count is down. It's the very frequent cause of death in cancer patients. Okay, sepsis can also cause disseminated intravascular coagulation, DIC, because you're killing the platelets, okay? You're killing everything, you're killing platelets, and so the body's system wants to produce more platelets, so the platelets that are being produced in a hurry are even more thicker than the normal platelets that we just killed. So what we end up with is a situation of bleeding and clotting at the same time. That's disseminated intravascular coagulation. Now, if your patient comes down with DIC, and DIC can occur also with what? Postpartum. Okay, can occur with women after giving birth. So if you see DIC, then the treatment, be prepared to give heparin first, because the concept is let us stop the clotting first, okay? Because we don't want too many clots. Let's stop the clotting first, and then we'll deal with, then we'll give the clotting factors later. Okay. There's another emergency called the superior vena cava syndrome, SVC. Now remember, your superior vena cava drains all the blood from your head, your right shoulder, and your right arm into your right atrium, right? So superior vena cava syndrome occurs when you have a tumor that's pushing on the the SVC, the superior vena cava, and this prevents drainage of blood from the head to the heart. So guess what happens if you have now a backup of blood into your head? You have increased intracranial pressure, yes. You now have severe headaches, and you may stroke out. So that's superior vena cava syndrome, and it is an emergency. You can also see something called syndrome of inappropriate antidiuretic hormone. Now, SIADH, okay, let's shift gears a little bit. Go to your endocrine system. What is the master gland of your body? The pituitary, okay. What does the pituitary produce? Well, go through your whole list, and you will remember that the posterior pituitary produces also antidiuretic hormone, correct? And oxytocin, right? So, antidiuretic hormone is produced by your pituitary sits in your brain. So if I told you that anytime you have a blunt trauma to your brain, anytime you have cancer or tumor in your brain, look for SIADH, because it may happen. Diabetes insipidus, it may happen, okay? Antidiuretic hormone is the hormone that prevents you from, your kidneys produce about 180 gallons of urine a day. Now, if we were to pee 180 gallons a day, we would just live in the bathroom. Yes? So antidiuretic hormone is the hormone that actually reabsorbs the water so that you don't pee 100 gallons a day. You go, maybe 2,500 cc's, okay? So if we didn't have antidiuretic hormone, we'd be in the bathroom. So you want to watch for syndrome of an inappropriate antidiuretic hormone, SIADH. And this can occur from cancer of the lung or the brain. You want to watch for water intoxication, particularly if your ADH isn't working, because you're going to be just filled with water. Okay? So you want to watch for that. Weight gain can happen. Now, inappropriate can mean too much ADH or can mean too little. Okay? So if you've got too much, then you're retaining, and if you've got too little, it means you're peeing. So remember, SIADH can be both sides. It can be too much or too little. So you want to watch for water intoxication. You want to watch for weight gain and personality changes. Why? Personality changes, your hormones are out of whack. Remember what happens, ladies, when your hormones get out of whack? Every month. Seizure activity can occur, and why is that? Again, there's pressure on the brain. So when you have pressure on the brain, and we'll cover that when we cover the brain later, a coma can occur. I'm going to ask you to speak into the mic so everyone can hear your question.
I just need the definition of medsurg, definition of each.
M stands for mustard-based drugs. E stands for estrogen. N stands for nitrogen-based drugs. S stands for steroids, all the other steroids, okay? And A stands for antibiotics. And if you look at your cancer treatments, you've got chemotherapeutic agents that are mustard-based. You've got estrogen-based, right, tamoxifen, that we utilize. N, you've got drugs that are nitrogen-based. S is steroids. We give prednisone a lot to people who have cancer. And A is antibiotics, because we also do give streptomycin and high drugs like that. I mean, very, very strong drugs like that to patients who have cancer. Okay, any more questions? All right, let's move on to laryngeal cancer. Since we are on cancer, let's go ahead and finish it. Cancer. With cancer, you've got progressive hoarseness. Progressive hoarseness. Okay? You have a difficulty swallowing or a lump in the throat. There's a burning sensation in the throat when drinking hot liquids. Laryngeal cancer, progressive hoarseness, difficulty swallowing or lump in the throat. There's a burning sensation in the throat when drinking hot liquids. Okay? And a persistent sore throat. Let me tell you what really brings people in with laryngeal cancer. Difficulty swallowing. That's what brings them in. The progressive hoarseness, the persistent sore throat, they just figure, I got a bug that I just can't shake. But that inability to swallow, when you can't eat, that's a problem. Okay, so that's what brings them in more than anything else. What are the interventions for laryngeal cancer? Laryngectomy. Now, there are two types of laryngectomies. There's a partial, and in a partial laryngectomy, only part of the vocal cord is removed, so you still have a voice post-operatively. And there's total. With total laryngectomy, the entire voice box is removed. You have a loss of your sense of smell. Okay, you have a loss of your speech. You have a loss of it all. Okay, and you have a permanent stoma with your laryngectomy. All right, now, what do you have to do? Preoperatively, you've got to teach your patient about alternative methods of communication, because even with a partial, we ask them not to talk immediately post-op. So even with a partial, even though they have a voice, we ask them, don't talk, rest your voice box, and we have to develop an alternative method of communication, whether it be by writing or signs or, whatever. But you need to establish that before he goes into surgery, right? Not after. Before he goes in. So that when he comes out, he knows, okay, now I got to write. Now I got to rest my voice. Post-operatively is not a good time to be teaching. So, pre-op care, routine medications. You're going to give atropine. What does atropine do? Dries you up. Atropine is an anticholinergic, so it dries you up. Okay? There is a question in NCLEX floating around that asks, why do you give atropine? Look for, here's the answer. You give atropine for its anticholinergic effects. That's the answer. Because atropine is an anticholinergic. Now, if you do not know what a cholinergic substance does and what an anticholinergic substance does, you need to go back and look up your neurological system again. You have to understand about sympathetic nervous system, the parasympathetic. I know you all hate this. And the parasympathetic nervous system, you hate it, but it's good. You need to know it, and it'll help you in your nursing. It really will. Okay. We talked about the communication mode that, before you have to discuss with him an alternative form of communication. The other thing preoperatively you can tell him also is that he can obtain an artificial larynx and he can learn esophageal speech, that he will get a speech therapist, that you will arrange, that the hospital or whatever will arrange for a speech therapist for him. And you've got to understand that sometimes you've got to initiate the communication or the contact with a speech therapist. Okay? Post-operatively, he's now got a bandage around his neck. All right? Now, you've got to check for hemorrhaging. Is there any hemorrhaging? Well, what you want to do is with your gloved hand, you want to slide your hand around the back of the neck and feel if there's any moisture or see if there's any moisture or blood or whatever. He will be in a semi-Fowler's position. Okay? Semi-Fowler's position. The other thing, another way that you can detect whether he is hemorrhaging or not is frequent swallowing. If he tends to be swallowing an awful lot, then he could be bleeding, and that's why he's swallowing. He's bleeding right here from the incision site, and that's why. You want to check for atelectasis. Okay, remember, number one complication of surgery, regardless of the surgery, is still atelectasis. Okay, so that's what you got to check for, and check also for pneumonia. Remember, if he had a total laryngectomy, he's going to have a stoma. If he has a stoma, now it doesn't matter whether it's a laryngectomy that he has it or whether he had to have an emergency trach. Anytime he's got a stoma up here in his trach, whether it's from, like I said, cancer, where you remove the larynx or whether it's just that he had an emergency trach, regardless, anytime he has a stoma, you've got to know how to take care of it. Okay, so you want to avoid water around the area. Please. Aerosols and sprays are a no-no. So you need to tell him, okay, or if it's a female patient, her, to avoid hairsprays. You want to tell him and his wife to avoid hairsprays, any kind of aerosol. Right now we have everything that's an aerosol, right? Air fresheners that are aerosols, yes? We've got Lysol's and aerosol. We have all kinds of things that are aerosols. So you want to avoid aerosols and sprays, particularly right around that area. Particularly right around the trach, because, it gets in, and that's very, very irritating. Not to mention who knows what carcinogens are in it. You also have to let them know that he's going to, at the very beginning, require very frequent suctioning. He's going to have to learn how to suction himself. Okay? He's going to require more frequent suctioning immediately post-op than later, but he's still going to require suctioning. So your job post-operatively is you've got to know you're going to have to suction him. Okay, remember, it stops here. It can't come out anymore. It stops here. So you've got to suction to keep that trachea nice and patent. Because, again, complication, atelectasis, pneumonia, okay, you need to do your job to make sure that he doesn't encounter any complications at all. You're also going to teach him the TCDB. What's TCDB? Turn, cough, deep, breathe, right? You're going to teach him that basic nursing. When I went to nursing school 100 years ago, we learned TCDB right after surgery, and guess what? We're still doing it today. And it's a wonderful thing. Turn, cough, deep breathe. There's some things about nursing that just don't change. You know why? Because they're standard, they work, and they're simple, and just there's no reason to change it. Do not reinvent the wheel. Turn, cough, deep breathe. When do you teach him about the coughing? Pre-op, exactly. All this is pre-op teaching. You teach him about coughing pre-op. You tell him pre-op, yes, I will be bothering you. Every 2 hours, I'm going to turn you. I'm going to make you cough. I'm going to make you take deep breaths. You tell him this pre-operatively so that he knows that afterwards, when you tell him to do it, okay, and when you get to him and say, okay, I need for you to cough, he will understand why. It's no surprise to him. You do not want surprises on this particular patient. Because he has a trach, and now remember the portion of your respiratory system that humidifies the air that you breathe is your nasal oropharynx. Okay, this portion right here, that's the portion that humidifies your air. Okay, remember we bypassed it now. We got a trach. So we no longer have that particular area that humidifies the air. So now we've got to humidify it. Okay, so teach him that too. And also teach him that oral hygiene is very important. Okay, very important. And you need to know that too. So you need to go in and clean his mouth out very frequently. And why is that? Again, it's dry. Okay, so you've got to